We'd like to welcome you to the Healthcare Revolution podcast, where we empower you to take control of your health, restore your trust in the medical system, and achieve lasting wellness. I am your host, Brad Powell, Doctor of Physical Therapy and owner of an award-winning foundation physical therapy here in the Salt Lake Valley. Each episode, we dive into all things rehab prevention, overall health, bringing you expert insights from leaders across the healthcare fields. Please note, while we aim to provide with the best knowledge and advice, the opinions shared represent those of experts in the field and are not to be replaced with professional medical advice. So let's revolutionize healthcare and wellness together. Welcome to the Healthcare Revolution podcast. I'm so excited today to talk about the changes that are happening in Utah in healthcare. As many of you might know, and some of you might not know, that Utah is ranked one of the lowest states in the nation based on the Department of Human Services. This is a national research center, has identified that Utah has one of the hardest states for primary care physicians to get access to. So we are changing a lot of things in Utah. Utah is one of the best states for being active, very active-centric mindsets here in Utah, but yet one of the hardest access states for healthcare. And we are working on changing those things here in Utah and leading from the front. So I'm so excited to have with us today a very unique perspective, Justin Carrier. He's the president of APTA Utah. I'll introduce him in a minute, but I want to talk about this topic because it's so important that people have access to care. If you have a primary care physician, you know how difficult it is to get into them. And sometimes it takes months, and you schedule an appointment way out and you can't make it, and then it's 3 months out, and it's just really hard to get into them. And a lot of people are resorting to go to urgent care, going to the emergency room for very routine things that can be treated by a physical therapist. And research shows that pain and injury is actually better to be treated by a physical therapist than any other provider. So we are breaking down walls, pulling the curtains back on all these things, and talking about the legislative changes that we're making. And some of these things might take a year or two, so maybe even more, to come out to the public and the public to understand. But we want to give you all these insights now. So welcome our guest, Dr. Justin Carrier. He is helping lead a lot of these efforts on the Capitol Hill and really create this revolution in healthcare with our profession. He's a physical therapist. He's an orthopedic clinical specialist. He's an educator. He's president of APTA Utah, which is our American Physical Therapy Association Utah chapter. He leads our profession here in Utah, and he's an associate professor at a Salt Lake Community College as a physical therapy assistant program. So he's shaping the next generation of physical therapist assistants and really advocating for policies and changes here in Utah. So this conversation is all about how we can elevate healthcare as a whole. And really excited to have this topic. So welcome, Justin, to the podcast.
Yeah, thanks, Brad. I'm excited to be here.
Yeah, I'm excited to talk about this topic. You know, this is something that we've been working on. I'm new to this. I'm assuming years. Right? At least the last 2 years, right?
Yeah.
That I've been a part of it. And making big impacts.
Yeah.
Things that haven't really passed in other states across the nation. We're the first to pass this primary care bill as physical therapists. And it's so interesting how difficult these things are and how much teamwork it takes.
Yeah. To
give us a little bit of insight into what led you to become the president of APTA Utah chapter in the first place.
Well, I've had some good mentors. I mean, we both went to the University of Utah, so Scott Ward is a huge influence and mentor there as a former president of the National Association. And then I worked with Steve Crandall, who's also been very involved throughout the years in the chapter and in just kind of the profession in Utah. And so that kind of inspired me to just see how I could be involved a little higher. So I was actually on the board. It's probably been 10 years ago now or so as the continuing education chair. That was kind of my first foray into it. This is my second go
run.
So you'd think after the first time I would have.
And how far are you in now? 3 years? Is it 3?
I am in my final, 3 years. I'm in my final year. But so I served that first. I actually did 2 terms on the board as Con Ed chair, and then had to to step off because that's in our bylaws that you can only serve 2 consecutive terms, and then you have to take a break. And then I was kind of just not done, but I still kept contact with folks on the board, and had some friends on there. And as the next term for president was coming up, there wasn't really a whole lot of interest, not many people expressing interest in it. And
for those therapists that are listening to this, tell us about why someone would want to get involved and what it takes to be involved.
Gosh, you know what? I think so. There's always the question of why join APTA? Like, what do they do for me? And I think that's harder to see on the everyday, like just the therapist in the clinic doing their thing. It might be a little hard to see what the National Association does. I think the best way to see what it does is to become involved. Because then you get in the room with the people that are trying to make the difference. And I think the biggest impact on me the first time I was on the board was I sat in this room. I was practicing still in an outpatient clinic at the time. And I was sitting in this room with people that in the business world are my competitors, right? But in this room right now, as this board of APTA Utah, we were talking about how we could make things better for everybody. And so that's, I think, the biggest reason to get involved is so you can see really like the answers that question of what do they do for me? And then you get to be a part of the conversation.
Yeah. I mean, I just think about the text threads we're on, right?
Yeah.
And if you're on these text threads,
Yeah.
I mean, we're talking hundreds of messages, right? And sometimes you'll get to a day and it's like we got 30 messages on this text thread, and just these great leaders coming together and sharing their ideas of what they think changes need to happen. Katie Mansell, she is our executive director. She is up on the Hill. She's studying all of these bills that come out, and sometimes there's new bills that come out, and we gotta do something about it, right? We got to engage with it and react to it, because if we don't, things can be taken away from us.
Right.
Like if a profession comes out and says, this particular thing that PTs do, it shouldn't be there, right? And if we don't engage with it, it can get passed and we can lose things in our scope.
Right.
We can lose, tools that we have. And Katie is always watching those bills, and she does such an incredible job. She'll just text us and say, hey, what do you guys think about this bill? Do we need to engage with it? Right. And then all of us are jumping on, sharing ideas, but there's so much effort. I mean, I know particularly 5 people, you being one of them, that are up on up at the Capitol, sometimes daily. I don't know. It seems like daily and all day long.
Yeah, it can be a lot. Luckily, I happen to be up there daily, but it is kind of like, we had a meeting up with some parties this week at the Capitol, and I found out that morning that this was happening.
It's always last minute.
It's always last minute, and luckily I was able to arrange my schedule to get there. But so it may not be like every day or all day, but it's certainly like you got to kind of be ready last minute to say, hey, yeah, I can get up there and meet with somebody, or I can go talk with this legislator or whatever. And so,
yeah, and it's super important, when just so everyone understands the process. Really, the bill is created, and typically, our profession would create it, or someone else's profession, and then if it is going along well, there's a lobbyist that supports it, or a sponsor, and then they present it, and then it goes to a committee. And then from that committee, if it's passed, then it goes to the Senate or the House, and then it has to pass both the Senate and the House. And then it goes to the governor, and the governor has to sign it. So really there's 4 steps, 4 big steps.
Yeah.
And if it gets shut down at any stage because someone doesn't understand the complexity or the simplicity of how it's going to help the public, it can literally be shut down in each phase. And you're paying a lot of money to these lobbyists or these sponsors to make it move forward.
Yeah.
And their job is to go around and meet with senators and teach them about this bill. So someone's got to pay the bill, right? And making sure that those conversations have happened. And then, we have all of our profession reaching out to these senators and patients.
Yeah.
There's so many steps to this, and there's so much effort that it takes to get there. And we have some really good bills that are supporting our profession right now that I'm super excited to talk about. But long story short, just give us a summary. If a PT or a PTA comes up to you and says, what does APTA Utah do for me? What is just like this short answer to that? other than just come see, come get
Yeah.
involved?
No, I would say that the answer would be APTA Utah and APTA. They protect, preserve, and progress practice. Everything that we can do in Utah, whether it's imaging or dry needling or even clear definitions of manipulation and what that means for us, that happened because, like you mentioned, this process of either someone brought it to the legislature or, some other means or ways, and then people got involved to take care of it. And if no one's doing that, no one is there to protect it. No one is there to preserve what we can do, and then no one's there to make these progressions that we're able to do.
Yeah,
that we've been first in the country on several of these things that wouldn't happen if people weren't there doing it, and that's what APTA Utah does.
Yeah, and one of the biggest thing, the priority of APTA is to, and this is nationally, and we are very supportive. I think they caught wind from us, but their priority is to get our profession paid better. Yeah. I think we can all agree that tuition is way through the roof. It's getting way too high, and we are not making enough income to be able to support it. I read one article, this was years ago, that said if a PT is over, if I remember right, $200,000 in debt, they are never going to pay off that loan in their lifetime. And that was like way eye-opening to me. I'm like, oh my goodness. Like most PT students are over $200,000 in debt. Yeah. And how do we combat that, right? So part of my role is overpayment. Like that has been that's a huge priority for me. I want every therapist in Utah to be making over six figures. As a doctoral level, provider, that's just something that should happen, especially if you're $200,000-$300,000 in debt in education. Yeah. We should match that. But, a lot of it comes down to, do we provide the value enough to get paid that much, right? Are we improving people's health enough to where we should get paid that much, right? And this new OPLR bill, Office of Professional Licensing, went and reviewed our profession for the last 10 years. Why don't you tell us about that bill? And I'll add a few thoughts as well.
It's an interesting bill because it's not just us. It's lumped in with several health professions. So it's, PT, OT, athletic training, nurses, PAs. So
what
does
OPLR do?
OPLR, from my understanding, is they are kind of an independent office within the state government that looks at professional practice. So like you said, it stands for the Office of Professional Licensure Review. And they've been tasked by the governor to look at licensing in the state of Utah and make sure, and just see if there are any changes that need to be made to scope, basically. So we were up this year, so they looked at our scope of practice and the things that we're doing and gathered. The thing I liked about it is it's very kind of independent, right? So they talk to us, they talk to other professions that might have an interest in physical therapy, but they're very open in the process. They do the research, they see what other states are doing. It's, in my mind, very comprehensive.
It is they interviewed me for an hour and a half, and it was very in-depth. It was a gentle interrogation.
Yeah, really. And I was on several phone calls with them. And even when they were ready to kind of say, here's what our final findings, and they had a phone call with us, and there were a couple things were like, wait a minute, where'd you get that information? And they're saying, okay, we'll go back and look at it again, and actually made some changes based on that. And so there was no as you know, the reputation, no turf battle stuff happening. Like, well, you can't do that because we do that, or we don't want you to do that. That happens often. It was just kind of like, here's what the research shows, here's where the stakeholders are at, and then they present this bill to the legislature.
So from my understanding, for our listeners, the Office of Professional Licensing Review will review every healthcare profession every 10 years and offer suggestions based on their comprehensive research to the senators through their research on what changes need to happen based on each profession they review. Yeah.
With the focus of, I think, public safety. So they look at the numbers and say how many incidents of harm happen in this profession and this profession. So they definitely look at it from like a protecting the public perspective as well, not just what do these guys think they want to do?
Great. And they really identified, I believe, 5 things in our profession.
Yeah.
Talk to us about those things. And I really want to add a few thoughts on some of these, because I've recognized in my, as I practice, how much of an impact they've made on me, how much improvement to access will make because of it.
Yeah. Remind me if I forget, because you put me on the spot.
Yeah, we'll do it. We'll do it together.
The first one is
DME.
Of course, I'm blanking. Okay, yes. Ordering DME, so durable medical equipment.
Yeah, tell us what durable medical equipment is, for those who don't know.
Typically, that's the stuff you think about, like wheelchairs, walkers.
Even like prosthetics. Like simple prosthetics. AFOs, like ankle braces.
Grab bars, grabber things, just any sort of medical equipment that a patient needs to perform daily functions.
Yeah, great. Name them all, and then we'll come back to the DME, because I want to discuss that for a minute.
So there's DME. Then they had recommended ordering labs, right? Lab testing.
Yeah, let's come back to that too. Okay. We'll come back to all of them.
Yeah. And then particular interest to me was PTA supervision. So the expanding the ability of how many PTAs a PT can supervise, which will expand practice and access.
Which is really similar to an MD to PA. Yeah. Right? How many PAs can...
analogous, yeah.
How many PAs can an MD supervise, right?
Yeah. I know there's a big one that's not coming to me.
Imaging.
Right, expanding imaging. So right now, rad techs can accept orders for MRIs and X-rays. They've recommended removing those limitations, so essentially we can order any image that's needed. Yeah.
So let's talk about DME for a minute.
Okay.
Durable medical equipment. I remember having a neurologic internship where we had it was mainly amputee. And we would work with the prosthetists, which would help us figure out, okay, this is what they need for their leg, whether it be above knee amputation, below. And we would write our recommendations, and then we would send an order to the physician, and the physician would essentially sign off on it. And most of these physicians, I would round with them as well. They're like, I don't even know why I have to sign this. Like, you guys do all the work. Why would I have to do that, right? We'd also measure all the wheelchairs, fit people for their wheelchairs, and then we'd have to do all this paperwork, send it to the physician would sign it, and then they could order that, and it'd be covered by insurance. Now it's totally different. It's literally skipping that step that was unnecessary, right? These physicians were like, oh, extra work for me to do,
right?
They're like, you guys are the experts there. Why do I need to sign off on this, right? So essentially it allows us to work with the patient, sign off on it, and then they can get it, right? And how incredible is that?
Yeah, that'd be great, because we are the ones that are seeing where these need to be used most often, right? Now, I do think that the DME in this sense does not include prosthetics and orthotics, which is kind of a bummer. That's kind of a different thing. I didn't know that. Yeah, but I have talked to wheelchairs, walkers,
any kind of home
sort
devices.
Of it's something you need to perform ADLs, activities of daily living. I believe.
What do we got to do to get prosthetics?
Are a separate thing. I think that's just looking at, that's something we've talked about with APTA National, and I think there's been a little bit of hesitation on that because of some politics that are going on there.
Sure.
That also makes a ton of sense, and I've talked to several prosthetists that are like, you guys are who we work with, and you're the ones making the recommendation, but it still has to go to the physician to sign off on it, right?
Yeah, I understand. Take that step out. To a certain extent, right? Prosthetics can be extremely expensive. I mean, just one leg with a microprocessor knee, we're talking $50,000. So
tens of thousands.
Maybe I understand that one a little bit more, but ultimately, at the same time, like the experts are doing it all.
The biggest thing is like pediatrics, right? And pediatric PT, you've got these guys that are making AFOs and other sorts of
these walkers for these little kids
that they're working oftentimes directly with the PT in figuring out what these kids need, but then they have to go to the physician to get those things signed off on.
Yeah, tell us about labs. Why did Oppler recommend that PTs are perfectly centered to be able to order labs, and then what happened?
Well, you might be able to speak into that one, because I know you were involved in those conversations quite a bit. But I think to me, it fits into the primary care model that we're trying to push. Not that we want to be the ones that are like necessarily directing patients like, well, this doesn't look good. You should, but okay, here's an example that I heard recently was, let's say you work with a patient who's got chronic knee pain, right? You've been working with them for quite a while. You know them very well. As PTs, we see them, our patients often. And this knee pain, this knee is just chronic inflammation, chronic pain. What's going on? So how great would it be as a PT to say, hey, let's order some labs and find out what the issue is. Those labs come back. There's some inflammatory markers. You start kind of this, maybe you've got some rheumatoid arthritis going on, and this is why this knee's not getting better. Then you initiate that process of, let's get you into a rheumatologist and figure out where to go from there, right? And so I think, again, I'm not the one that necessarily wants to have the, well, I want to say wants to have the responsibility, but needs to have the responsibility to take action on that, to manage that. That's not my, that's
the
not
management of labs is not our role.
But the fact that I'm working with this patient that's having this issue that's not resolving, something's not right. Let's order some blood work and see.
And that's what therapists are really good at, is identifying when things are not right.
Right. Yeah.
Our job is not to intervene and say, well, we're going to, this is a medication. None of that, right? It's purely to see if there's something else going on, or if we're on the right track and things might just be slow, right? But if we have to get them back into a physician and that physician takes 3 months to get into, and we're only seeing them for 6 weeks, it literally delays the patient, right? But if we order labs and they all come back normal, it's like, great. Well, at least we know we're on the right track, and it's just a little slower.
And if they order labs and they come back abnormal, then we say, let's get you into your physician. And see what the next steps are, right?
And the same thing with imaging, right?
Yeah.
Our job is not to manage the imaging. Our job is to identify if there's anything serious going on and move them to the right direction.
Fast track things.
Essentially, we are the entry point for patients for musculoskeletal pain, anything muscle, joint, sprains, strains, those kind of things. We're the experts in that area, so we need to be ruling these things out, right? And so important to do. But tell us, I'll speak to this a little bit.
Do it.
I had a lot of these conversations with labs. I'm new to the profession as of 7 years, right? Like, I've been in it long enough to know what the older generation feels and what the new generation learns. And labs are deeply in our studies, right? They are on our boards. We're expected to know them all. We work in the ICU. It's important for us to know those. But even for general things, like if people can't tolerate exercise, if people have electrolyte deficiencies, like these are all things we would order labs for. And the public can actually order their own labs.
Right.
So I don't really see the issue, but is what happened, in it ended up not even getting to the committee, the Business and Labor's Committee. Because OPLR did all this research and they said, PTs are perfectly centered to do this. There would be no harm. There would be no safety issues. And the senator that was supporting the bill ended up calling 2 of his therapist friends. And I asked him, I said, well, were they older or younger? And he's like, well, one was older, one was younger. And the PT said specifically, I don't know why I would ever order those. And tell us what you see, what your insight is because obviously that's super frustrating for all the work that we've done, right? And it literally stopped it from 2 PTs in our community saying what they said, right? And it's so much work that we did and really got shut down by those 2 PTs. But tell us about kind of why that would cause frustration in our profession.
I think it's happening, but there needs to be a little bit of a mindset shift from, if they would have answered that a little differently, right? Rather than saying, I don't know why I would ever order those, to, interesting, I think that could I could see the potential in that, or something, rather than this, why would I, to, what would that do for me if I could? Right? And they may never do it, which is fine.
Just because it's in your scope of practice doesn't mean you actually have to order it.
And if you don't feel confident or comfortable doing it, don't.
And we actually, just to give some context to what you're saying, we went to the University of Utah. We looked at all the curriculum, and we got one of the professors to commit to doing a weekend course for anyone that felt uncomfortable with it. So we had all this back end work, months and months of work,
set up and ready
literally
to go.
Shut down in 2 calls. But tell us any other thoughts that you'd add to that.
No, I just think that's the main thing, is that I don't know if I want to say, more of an abundance mindset, but more maybe of just a like forward thinking mindset. Just because I think it's an age old issue, right? Just because you've done it one way or it's been done a certain way doesn't mean it can't be done a different way, or doesn't mean that it shouldn't be done a different way. And I think sometimes we as humans and as PTs, we kind of get in this, like, this is just the way I do it. I don't really think about that. So then the natural answer is, why would I ever need to do that? Order labs? I don't think I would ever need to do that.
Yeah.
Rather than saying, oh, interesting thought. What would it be like if I could do that?
Yeah.
Right.
Being open to the future.
Yeah. And then maybe I never would, but that'd be great to have that option.
And I think one of the biggest issues in our profession is we don't forward think, a lot of us. It's like, well, this is just the way our profession works. And maybe for most professions, right? We don't think that our profession actually could change, that our scope of practice, what we're allowed to do, could change over time. We just think, well, it's always been done that way.
Yeah.
Right?
And here's something you mentioned, scope of practice. I was able to be on a panel about a month ago speaking about primary care physical therapy. And one of the panelists on that panel is colonel in the Army. He's an Army PT. And he's like at the top of the military health system. There's like 10 people that make all decisions for military health, and he's one of them. And he's a PT. And something that he said has just really stuck with me from what you said. He's like, in the military health system, PTs are given the opportunity to practice to their training, not to what some body said this is what you can and can't do. And that really struck me. So, you're talking about, well, this is what our scope's always been. Like, let's forget about what the scope is. That's what the legislature said we can and can't do. Let's look at what we're trained to do. Labs, it's in our training. So why shouldn't we be allowed, those that feel like that would be helpful to their practice, to
that
order
gives
those?
So much good insight.
Doesn't it?
Because you think about the level of training that we get.
Yeah.
We get really like sky level training, like super, super high level training. And then when we get to practice, it's like, well, you practice here.
Right.
It's so interesting to me.
Yeah.
It's like, why did I learn labs in the first place?
Yeah.
I remember memorizing every single one. I knew them. I could rat them off like top of my head. Yeah. And I knew why I'd ordered each one. But yet I never get to order them in actual practice.
Yeah. There's this phrase we throw out there often, like practicing to the top of our license or the top of our scope. Like, I think we need to change that. We need to be able to practice to the top of our training.
Ooh, I love that.
You know what I mean?
That is so good.
And this whole talk with the primary care, I think it's awesome and is exciting. But one of the things that drives me crazy is they've been doing this stuff that we're trying to do in military medicine since the 70s.
Tell us about some of those things that they're doing in the military.
Well,
this is in the military and in prisons, right?
Right. Yeah, I believe so in prisons, but certainly in the military. So, in the military, they've been frontline providers since the 70s because
we're talking triage.
Yeah, triage, and because the military recognized we don't have enough providers for the need. Right. Yep. So they said, okay, PT, well, you've got this training. We'll let you do that.
Even up to emergency medicine too. Yeah. Right. Like frontline, we are in the battlefront, right?
PTs are embedded with combat units. You know what I mean? It's like.
And if you knew the level of education, the emergency training, triaging is part of our training as well.
Yeah. And they're my younger brother is a PT in the Air Force. His education was no different than mine was, as far as the curriculum and the requirements and the things he was doing, right? But he's allowed to do stuff that I can't do.
Don't get me wrong. I really want to, from the other side, talk. Like, we're not talking physician level trained, right? We're not talking emergency physician, like emergency nurses. We're not talking that, right? We are saying that there's a huge limit in access to providers.
Yeah.
And PTs are trained on emergency care, not at the same level as other providers, but it's an additional provider that can help out when when we don't have enough, right?
I think it's the triage aspect, right? Like we've talked about this already. We might not have the training to manage XYZ, but we certainly have the training to say you need management for XYZ and let's get you there.
Yeah, imagine if you had 1,000 people go to an orthopedic surgeon and only 10 needed to be there, right?
Yeah.
If we can help filter those for the orthopedic surgeon, how much more freedom would that develop in getting the right people to him?
Yeah.
Now, if the orthopedic surgeon has to filter out all 900 plus of those people and send them other places, it really limits access for the patient to get in. So that's really the weight of what we're talking about here.
Yeah.
Any other thoughts on how they do things in the military versus how we're doing it?
No, I mean, we're getting there. So imaging, they can order images that they feel are appropriate. There's some prescriptive authority in terms of like non-opioid anti-inflammatories, prescription ibuprofen, that kind of thing. And then just the recognition that when it comes to musculoskeletal issues, PT is the one that should be seeing that person first.
I remember doing my internship in the VA. Did you do?
I did actually, yeah, acute care, but yeah,
it's very different. I mean, if we need a new wheelchair, we walk downstairs and got a wheelchair.
Exactly. Yeah. Yep.
Like it's so different. Like any equipment you need, it's there.
Right.
That vet needs a different leg prosthetic. We get it. Right. Yeah. And when every acute care patient that was discharged, they would not discharge them unless PT had cleared them first. Yeah. And I remember as a student, I'm like, that's a lot of weight.
Yeah.
You're asking me if they're ready to go home? I'm like, all right. Right. But yeah, that's an efficient system. Yeah. And it was very team-based. It's like, all right, what do you think? What's your concerns? Can we combat those concerns? Can we figure out a solution? And then when everyone said yes, the patient was able to go home. Yeah. Right.
Yep.
And that's the system that we're trying to create here. So what real barriers that do we have in the public, like the public's perception to primary care providers? What barriers do you see there?
I think just an understanding of when can I go to a physical therapist? What should I go to a physical therapist for? Maybe even a little bit of perception of what physical therapists. I think most of the public, when they think of physical therapy, they think of kind of your traditional outpatient orthopedic practice, right? But even more so, in school we had this thing with an interdisciplinary little activity, and this didn't happen to me, it happened to a classmate, but one of the students there, I think it was nursing or something, they're going around saying, this is what we're studying, and my classmate said, I'm in physical therapy, and this nursing student said, oh, so you guys watch ESPN and give massages all day. Oh. Right?
Like,
and unfortunately, I think, girl. Right? Yeah. But unfortunately,
and all you do is provide medication, right?
I think that's part of the perception, though, is like they don't think. People think I have an injury, and it's still just kind of like I need to go to the doctor, or like you mentioned, even urgent care, which is kind of an issue in and of itself. But so public perception of like if it's a joint or muscle that's hurting, then a physical therapist can help you decide what needs to be done.
And is literally the best provider. To be seen, right?
Yeah.
And we've dug a ton into research this year, and we found a lot of really powerful articles, really high level education articles that identified that PTs are the best provider for managing musculoskeletal issues, right? Anything pain or achiness or injury related, they are literally the best provider to manage
movement related, right? If it's something that helps you move your body, that's what we do. Yeah.
I mean, one particular article stated that primary care physicians, their diagnostic accuracy was like 30%. And ours was 75% compared to an MRI, and it really highlighted like, why go to a primary care physician to be diagnosed at 30% level when you can skip that step and go to the place where you're probably going to end up anyways, right? To the PT, because if the primary care physician will then refer you to a physical therapist for an injury.
And what's that referral going to say?
What's probably the wrong diagnosis.
Well, it's going to say eval and treat, right?
Yeah.
They're not, the physicians don't tell us what to do. They say, you do your thing.
Yeah. And and last thing I want people to do is think I'm like bashing primary care physicians here, because that's not the goal.
No.
They are trained in a very different level.
Yes.
And their job is to get us the right people. But now the public needs to understand you don't even need to go there.
Right.
Go to a primary care physician for anything illness related or disease. You know, everything else, any kind of injury, pain related, just go to a PT first. That has been direct access is the term that we've had since the 80s.
Yeah.
And the public still doesn't understand that.
No one knows what direct access
I blame
means.
it on our profession for doing a poor job marketing.
Yeah.
But ultimately, we need to teach people more.
Yeah. And I think primary care, people resonate with that a little more, right? Like,
absolutely.
That's where I go first.
Yes.
And so hopefully the primary care shift and mindset and just recognition helps with that public perception of, what is this direct access term? I don't know what that means, but
I love it.
Primary care. Okay. Yeah, I get that.
We didn't talk about imaging, the last piece of the Oppler bill.
Yeah.
Tell us about that expansion and how that's going to help the public.
Again, I think it eliminates extra steps. It eliminates extra costs. If as a physical therapist, seeing a patient, again, we see them often and frequently, and we're familiar with the condition and what's happening. If we just have the ability to order more than just a couple things, but whatever we feel is necessary, whether it's CT or maybe a bone density scan, something like that, that just is one less step, one less visit, one less cost to the patient to have to go to the physician to get that done.
Yeah, and keep in mind, if you're any other provider besides PT listening to this, the language in the scope of a PT says that they order imaging with the intent to refer. Right. The full intention to order any kind of imaging is if we see any abnormal results is to engage with the provider that's going to manage that.
Right. Yep.
And I think that's really important to know. Our job is to identify issues.
Yeah.
If there's an issue and that's not in my wheelhouse, here's the person that's going to help you with that next step.
Right.
But I can't tell you how many physicians are like, you ordered the MRI, you're the man. Like, thank you so much, because it literally saved so much time and energy for the patient. And now they walk into the office and the physician already has that MRI and they can review it and we can speed this process up.
A visit to the physician to get the imaging ordered, a visit to the physician to now interpret the imaging. So we take out at least 1 or 2 visits with getting that done, and then they have it ready, and they go to the physician, and then they have those discussions.
Yeah, and we talked about access, take you through. I mean, that's a month and a half process, and we could have just sped that up so much.
Yeah.
So tell us, where do you feel like are the biggest opportunities to move? We'll just say healthcare. I was going to say the PT profession forward, but move the healthcare system forward. Specifically in Utah, where do you see the biggest opportunities right now? Because up on the Capitol, these senators are really interested in improving health. That's just been really clear. They're just like, the opioid crisis is just out of hand. We need to change healthcare in Utah. Like, what do you feel like are the biggest opportunities we have right now?
Well, physical therapists are movement specialists, right? And I think, I don't know if it's been called this or not, but I'm going to say, I think we have an epidemic of inactivity in our society and in the world, really. We just don't move like we used to. And if there's a profession that are movement specialists that can help an individual move more and move better, that's going to change health. Because I think so many of our health problems right now, so many of the healthcare issues are stemming just from our bodies are meant to move and we're not moving them because of our lifestyles. It's just how society is developed. So we got to change that. So if we want to change healthcare, we've got to get healthy movement back into the discussion.
If you were to say, anything to our profession, what do you hope our profession does in the next few years? The people listening to this podcast and they're a physical therapist or PTA, what do you hope they do? I love that you said forward thinking.
Yeah, I think.
What else would you add to that?
Well, that would probably be the main thing is just look at how can we progress? How do we really, if we keep saying we're movement specialists and we have the answer to musculoskeletal issues, then we need to embrace that and run with it. And say, how do we continue to progress that idea? And then it comes down to, I think there's kind of a joke. We're terrible marketers. We don't talk ourselves up enough. And so as a PT or a PTA, have those conversations. I mean, you and I both, you go to a family gathering, hey, my neck hurts. Can you take but really kind of encouraging friends, family, all the people, tell people about this.
Go to a PT.
Go to a PT.
What do most PTs do? This is what I see. I don't know if you see the same thing. When you're at the party and someone's got neck pain, you push on it, make it feel a little better. And typically we do them a disservice by giving them a bunch of exercises, and they try to manage it on their own, and then it doesn't work, and then they don't trust you anymore.
Yeah.
Right? Mm-hmm. What I hope that our profession does is respect the process.
Sure.
Right? Yeah. I've seen so many healthcare providers that PTs did them a disservice. Nurses, physicians, surgeons, majority of them never go to PT. Why? They know a buddy that's a PT, and they'll ask them, hey, what's 5 exercises that I can do for this neck pain? And the PT thinks that they're different and says, here's a list. And then it never gets better, and it doesn't build any trust.
Yeah.
They actually lose trust.
Right.
And I've treated tons of physicians that I'm like, you need to understand the process just like everyone else.
Yeah.
I cannot expedite your healing because you're a physician. You need to come into the clinic, be evaluated, go through the steps just like everyone else. We're not going to treat you any different than any other patient.
Yeah.
And then some of my top referral sources are those physicians. Because then they believe, and they're like, oh my gosh, you got me better, and I haven't been better in 2 years. Right? But now they understand the steps and why it's important to go through them, and they no longer print 5 exercises for all their patients with shoulder pain anymore. Right? But we give the freaking wrong idea.
Yeah.
Like when we do this consistently with our family, our friends, if you really love them, you care about them, get them into your clinic.
Yeah.
Treat them like every other patient.
Yeah.
Have high accountability with them and high expectations. If you want to get better, this is the steps.
Yeah.
Don't try to change it for them or customize it in that level, because it truly does them a disservice.
It's interesting you say that. I think that's something I've kind of naturally done. I have family ask, often, my back hurts or this hurts, and what can I do? And, I am guilty of saying, well, you could try this and this, but then I always follow it up with, you should go see a PT. I can find a name for you. I can get a referral for you, but to get this really taken care of, you need to go in.
Yeah.
And do the process, like you're saying.
I agree. And that's something I hope that we do more, is respect our own profession. It would be rare, if physicians started treating out of homes. It's like, let me just prescribe you that medication real quick, right? They don't do that. They say, come see me in the clinic.
Right.
Same thing with, when patients discuss finances, all of a sudden we're like, well, let's actually decrease the plan of care in half because you have a hard time paying for it. Has a surgeon ever talked to a patient about finances in a surgery? If the patient's like, I can't afford the surgery. And
we'll
he's
do
like,
half of it.
Sorry, we'll do half the surgery. But in the PT profession, we do that all the time.
It's true.
It's like, let's do, we were going to do twice a week, but because you have financial issues, let's do it once a week, right?
Right.
And I'm not saying that we shouldn't worry about patients' financial concerns. I'm saying respect your profession enough to allow the financial people to talk about the finances, right? And you do your job as a clinician. You don't need to engage with that. And you shouldn't do a disservice for the patient by giving half the quality because they can't afford it. We would typically say we have pro bono options or we have payment plans. Yeah. There's other options, right?
Right.
But in order to get you better, this is the prescription. A physician would never say, you want to get better, here's this antibiotic. Oh, you can't afford the whole pill, thing of pills. Let's just do half. You're right. Right. No, you need to take the full prescription.
The full thing. Yeah.
Right. And we prescribe all the time.
Right. But
yet we change our prescription based on people's demands in their life. It's like, oh, it's inconvenient for you to come to PT. Yeah, let's see if we can cut it in half. Half the prescription. Yeah. It's fine.
So I guess it would just be stop shortchanging ourselves, right?
Yeah. I totally agree.
Yeah.
Like, I think we shortchange ourselves way too much, and we need to respect ourselves more and hold the line of what we know.
Yeah.
You know, because if I was to prescribe to someone I truly love and care about, it'd be the full prescription.
Yeah, absolutely.
You know?
Yep.
I think we'd be amiss if we didn't have this conversation. The PTA to PT relationship. It's part of your heart.
It is.
And you obviously teach PTAs. You've taught some of my best PTAs, and so appreciative of that.
Yeah.
I have PTAs in all of my clinics, and I truly believe in what the power that they do. I had a comment from someone in a gym yesterday, and I really want to start with this because it highlights the potential public perception about a PTA. She said, "I want to come see you. I don't want to be passed off to a second string."
Okay.
And I just laughed. I'm like, I don't have any second string at my company, so
yeah,
you know.
Yeah.
But tell us your thoughts on that. Just that comment alone.
Yeah. Well, I think the first thing that needs to change 100% is this. This is a relationship. It's not it's a cooperative relationship. It's not I mean, yes, a PTA has to practice under the supervision of a licensed physical therapist, but there's no possessive. A lot of times you'll hear, "Oh, hey, so-and-so, this is Brad. He's my PTA. He works with me." It's a small thing, but it does kind of put in that little bit of like second string mentality, right?
I'm too busy. Got to get my second string.
Yeah, and this is my PTA and my PT. It goes both ways, but we've got to change the verbiage of just being like, "I'm a PT. This is Brad. He's a PTA, and we're going to work together to get you better."
Yeah, and I take it one next level. We train our therapists to say, "This is Piper. She's a therapist in our clinic. We're going to work together as a team
There you go.
to get you better."
That would be amazing.
Because we're all therapists, right? We are on the same team.
Yeah.
You know, and yes, her title is assistant, but she is a therapist that's high level trained. She knows exactly what you need. I'm writing the plan, and she's carrying out the plan.
Yeah.
And if there's any hiccups in it, she's going to let me know. And we're going to jump back in together.
Yeah.
My job's to diagnose, her job's to treat. Right. Yeah. And we work in tandem together to give the best patient experience to every patient.
I think, you go back to just tradition and history and stuff. I think what would be best is to stop differentiating PT and PTA, kind of like you're saying. And we're just all physical therapy clinicians. We have different training and different focuses, but we're all clinicians, right? And I think there's an understanding of that, but it's not common. I mean, even with the APTA strategic framework that just came out, in a lot of them it says PTs and PTAs. It separates them out rather than, and I would love to see it say physical therapy clinicians or providers or whatever that word might be, but we're all providing physical therapy to patients.
Yeah.
Right.
I love that.
And I will say too, and I don't know how you have this conversation with patients, especially something like that, but PTA education, they are the interventionists, right? If you look at a hierarchy, maybe that's not the right word, but the training, physical therapists are trained to do the evaluation and the plan of care portion of, and we learn interventions, but the PTA learns interventions. That's their whole education focus. They are the intervention experts.
Yeah.
And so, I mean, and I would put a PT up against a PT on
intervention any day.
Any day.
Yeah.
Any day. In fact, I think it's funny. I helped teach some classes up at the U, therapeutic exercise class. And I remember the first time I did it, I was was helping in this DPT program, therapeutic exercise class, at the same time that my PTA students, I wasn't teaching it, but are having their therapeutic exercise class. And Brad, I'm not kidding. You could teach those classes together. The content they were doing was almost identical. They should teach it together. Wouldn't that be amazing?
Because the thing is, like, then they're working you could call it interdisciplinary, but it's same discipline,
intra-professional,
intra. But yeah, like get the PT and PTA to work together as they learn those interventions.
And then we get rid of this, because I think one of the biggest problems is we don't learn what PTs do in PT school. We're trying to change that. We've got some stuff going on with the U to introduce early to students here's what PTA education looks like. Here's what a PTA scope looks like. Here's how you work together with a PTA.
Yeah.
Because you get into practice and you've never worked with a PTA and you've got all these misconceptions about what they can and can't do. And it's so common to hear a PT or a PT student say, oh, you learn fill in the blank.
I remember when I first graduated, right? I was with a PTA, and I hope she listens to this. I was so intimidated by her.
Were you?
I would write things in my note, and I would just second guess myself. I'm like, should I write that? She's going to make fun of me, or she's going to like come ask me questions, or if I don't write a good enough plan, she's going to come hound me, right? Like there was so many like insecurities because I'm like, she knows a lot more than I do.
Yeah.
Right. I have a higher level of education than she does, but she's got a lot more experience. And, you know, I've just been so blessed with so many great PTAs in my life.
Yeah.
And they have taught me an immense amount of interventional success.
Right.
And teaching the skills to patients and how to expedite that even faster. Because we do spend a lot of time on diagnosis, right?
Yeah.
There's a huge portion of what we do, triage, all like imaging, all these other classes, wound care, like all these other classes that consume our time where we don't get to focus as much on the intervention pieces. Right. Then these PTAs come in and they hit it out of the park.
Yeah, absolutely. And I think the other thing too that needs to change is this kind of mentality of just a PTA or why didn't you go to PT school?
Yeah.
Who cares? Like,
that's like saying you're just a mom, or just, you know, like no mom
fast
ever
way to get kicked out, right?
Yeah,
go sleep on the couch. But there is no just a PTA. Like, for whatever reason that they didn't go to PT school, it doesn't matter. Like, there's no just a PTA. They're just as valuable in what they provide to patients as what the PT does. It's different roles.
Very different roles, yeah.
And different focus. That's
what do you hope
down
every
to.
PTA understands? What do you try to instill in them in school?
Just that they are as knowledgeable and as valuable to the care team as the PT that supervises them. That they maybe... I don't know. I teach my PTAs very much as if they're PTs. And I teach my PTAs as if they're going to work with me. I expect my PTAs to be, you know, knowledgeable, to be adaptable, to be willing to learn. And so I guess that would be the message too, is just be adaptable, be willing to learn. You don't learn it all, just like PTs don't learn it all. But also be willing to like stand up for yourself. Don't just be like, oh, well, the PT said this, so.
Yeah, jump in, intervene, and say, I disagree.
Yeah.
Like, can I give my 2 cents on that?
Yeah, I always tell them, like, as long as you can explain why you're doing something, then it's not wrong.
Yeah.
Someone might have an idea of what's right or wrong.
I love when one of my therapists will come up and say, what do you think about this instead? Right. I love when they come with available solutions.
Yeah.
It's like, we're getting stuck with this patient.
Yeah.
Because sometimes I want to take them back. I'm like, all right, I'm diving back in. But I love when a PTA says, what do you think about this instead? Like, well, maybe we missed this. Can you look at this again and tell me if you think it's like maybe we got the wrong diagnosis, right? Which can happen, right? It's like, I gave you the wrong plan.
Right.
You worked the plan that I told you to work, but it didn't work. Why didn't it work? I probably got the wrong diagnosis, right? And you giving the insight saying, it's not working. Can you look again?
Yep.
Right. And tell me your thoughts. And then it's just like cohesive team.
Exactly.
Right.
Yeah.
One thing I would say to our PTs that I really hope they understand is spend time with your PTAs.
Yeah.
Like they know so much more than you think they know. And one thing I wish PTAs came out of school more with is more confidence. I think they're just a little too timid.
Yeah.
And that's really what I instill in our PTAs as they come out. Like, be confident.
Yeah. Well, and realize to go along with that, I did one of my clinicals in school out in California with a great therapist, but he was very anti-PTA. And his reasoning was they just don't know the stuff. Well, spend time with them, like you're saying, find out what they do know, because I'm sure there was a misconception there of what PTAs know, and then fill in the gaps of what they don't know. If you have a certain treatment style or a certain technique that you've learned, teach them what that is so that they can complement what you're doing.
Yeah. And I have 3 PTAs on my team right now, and I've personally trained all 3 of them.
Mm-hmm.
And each one of them have their own personalities. Each one of them have their own strengths. And each one of them have taught me very particular things.
Yeah.
And I'm so grateful for each one of them. I mean, my PTA in South Jordan, her name's Missy. Every patient says she has gifted hands.
Mm-hmm.
I'm like, I've gifted, right? Like my hands are good, you know, but I get more compliments about her manual skills than any other PT in my company.
Yeah.
Right.
Yeah.
And it's really interesting to me because I hear a lot of compliments, right, from all these different patients that reach out to me and tell me about my therapist. But that one is tried and true. Yeah. Like that PTA in particular has very gifted hands.
And don't you love when a patient comes in and goes, "Is Missy here today?" Yeah, she's, "Oh, good."
Yeah.
Right?
Yeah. And then like Piper, everyone tells me about how she is so friendly and so connected, right? Like she deeply cares about people. Yeah. And I know I'm heard. I know I'm validated when I come, right? Right. And there's certain compliments you get and certain things that I've learned how to do better because of the skills they bring to the table.
Yeah. Yeah.
So, okay, we're going to shift gears and we're going to end with this. Okay. I want to hear from, you've been president now of APTA Utah for almost 3 years. Mm-hmm. What are your biggest takeaways from the experience in being in that role now?
I was just thinking about this the other day. Again, it comes back to like, if you want to know what's being done, come be involved. And when you are involved, you get to see it's easy for someone to say, "Oh, they don't do anything." But there are so many passionate people involved. And that's why they're involved, is because they're passionate about our profession. They're passionate about improving the profession. You know, I mean, the APTA strategic framework that came out, improving payment, improving access, and improving the patient experience, basically is the 3 main focuses now of our national association. And it's passionate people that see the value of physical therapy and what it can do for patients that are driving that. And so it's been really fun and rewarding to be in the room with those people and see the work that's going into progressing and protecting the profession.
Yeah, I love that. I think people would be very surprised on how much impact they could make if they were involved. Mm-hmm. How would you recommend that someone get involved?
Yeah. I mean, you can run for a position on the board. There's always openings every year because of the way we rotate. But even if you aren't sure about that, there's plenty of committee work that can be done, whether, you're interested in payment, call Brad, come be involved see what's happening on the payment side of things, or in the legislative process, or even,
I got plenty of work for you to do. I'll put you to work.
Or even just planning, hey, you haven't loved our conferences the last little while, come help us plan it. Right. Yeah. You don't have to be on the board to be involved. There's plenty of other opportunities to have a say and to kind of get your feet wet.
Yeah, and if you reached out to a board member and they said we don't have a lot going on, reach out to a different one. Yeah, because we got a lot going on.
We have a lot going on.
And there's things that we need help with, and there's things. A really engaged board member will have a list of 10, 15 things that need to be done. Right. Yeah. A less engaged board member, they'll show up to the meetings and that's about it. Yeah. And it is what you make it.
It is.
That's what I've realized. Like as a board member, you are only engaged as you want to be. Yeah. Right. And if it's like, well, I haven't had a lot to do, it's probably because you're not thinking about it and you're not asking. Yeah. Right. And you're not figuring out ways, because ultimately we're all entrepreneurs on the same board together. Mm-hmm. And that means we got to navigate these waters as they come. Yeah. And we don't even know what's coming next. Right. But if you are involved and you are engaged and you're having the appropriate networking that's happening, you will know what's going on and know how to help.
Yeah. I was just going to say, I think that's the other thing, that our profession is just like any, like networking is, you might not think it is, but it's really a big deal. And that's something I've also enjoyed, being involved at this level and being able to interact with some people that are more nationally involved, whether they're forward-thinking PTs that are like Katie O'Bright that's making progress in the primary care space, or these people I interacted with a month or so ago, like making the connections with these people and seeing that it's happening, what's happening more than just in our little sphere, but also networking with the other people on the board and seeing, again, that passion in your own backyard that people have for what we do.
Absolutely. As we close, is there anything else that you hope that the public or our profession or healthcare in general needs to know?
Well, I got my Choose PT shirt on here.
You're slightly biased.
So, yeah, I'm slightly biased. But, I truly believe what we're saying, that physical therapy can be a key to solving a lot of the issues in healthcare when it comes to access, when it comes to just health in general. If we could be involved, if we weren't thought of just like the repair after the injury, but the preventative measure to the injury.
Yeah.
I didn't say that well, but
yeah.
So, and part of that's a whole nother conversation, but just, I believe that as physical therapists and physical therapist assistants, we really can help improve society and the health of society and improve access to healthcare and just help people live lives that they want to live.
Love it.
Yeah.
Well, thank you for joining us today, Justin. Thank you for all your efforts on the board throughout these years and our profession.
Yeah.
You see things on the front lines in school and you're teaching new classes all the time and this new generation of providers. And it is beautiful work that you're doing. Yeah. So thank you for all your efforts.
Thank you, Brad.
Thanks for joining us today.
Thanks. Yeah.